Calcium chloride or calcium gluconate is not the antidote for a calcium channel blocker overdose. Calcium channel blockers work by inhibiting voltage in myocardial calcium channels. This slows the heart rate, and hence, this is why you would give it for a patient in a rapid AFib or other types of symptomatic atrial tachycardias. They are also very effective vasodilators. This is why they are very commonly prescribed to people for hypertension. Overdoses are probably more common than you would think. They are often accidental, as 87-year-old Meemaw can't remember if she took her pills today, so she takes them again to be safe, and then she repeats this 5 times in a single afternoon. Or your old person is like my wife's grandmother, who arranged her pills in her weekly pill container by color and not by which day you should be taking them. And we all know the scenario where the child gets into grandma's meds and eats them, causing an overdose. And of course, sometimes people try and commit suicide by overdosing on these drugs, and that's actually quite effective. Calcium channel blocker overdoses tend to be disasters. Not only do they cause direct myocardial depression, but the patient gets humongous vasodilation. So not only does your patient have a depressed heart that isn't contracting effectively, but they will have a vasodilatory distributive shock on top of all of this. And with the profound shock state comes renal failure, kidney failure, liver failure, bowel ischemia, and DIC. And just for an added bonus, calcium channel blocker overdoses impair insulin release, and patients can become hyperglycemic. And if all of that wasn't spicy enough for you, verapamil and diltiazem are the most commonly prescribed oral calcium channel blockers. They are sustained release, so the overdose is going to keep going and going and going. Yes, it makes total sense to give the patient calcium, and you absolutely should. Gluconate, chloride, doesn't matter. However, calcium is not the antidote or magic bullet like they tend to teach you in paramedic school. It's kind of a crapshoot if it's going to work or not. It might help a little bit, or it might not help at all. Treatment is aimed at improving myocardial contractility, fixing bradycardia, and shrinking the vascular container. The first line therapy for calcium channel blocker toxicity is high-dose insulin. Why, do you ask? Because insulin at high doses is going to cause the heart to contract more forcefully. Now, you can't just dump a huge continuous load of insulin into the patient because they will get life-threatening hypoglycemia, so you also have to give them a dextrose infusion. Glucagon is also of benefit because it increases myocardial contractility as well. The catch is that it also has to be high dose. The 1 milligram that you carry on the medic unit ain't gonna cut it. Plus, insulin is much more preferred because plainly, it works better. The glucagon thing is more anecdote and dogma. The current peer-reviewed data doesn't say that glucagon doesn't work, but it isn't necessarily all that supportive, and it's pretty clear that high-dose insulin works much better. These patients are going to need vasopressors to shrink the vascular container. However, when I say that calcium channel blocker overdose patients are going to be in a vasodilatory shock, they're going to be in a freaking ginormous vasodilatory shock. Norepinephrine is the first-line pressor of choice, but from experience, you're going to be adding epinephrine in short order and probably in rapid fashion all of the other ones, like vasopressin and phenylephrine. It is an uphill battle with these patients. Now, with most toxicities, when all else fails, you can usually dialyze the patient and get the poison out of their system. This is not the case with calcium channel blockers because of their very effective nuclear plasma binding ability, liver absorption, and the overwhelming cardiovascular collapse that they cause. Dialysis usually not an option. These patients may need VA ECMO to bypass the heart and lungs and provide oxygenation and flow until the toxicity can be resolved and the blocker can be cleared from the body. The last patient I had with this did end up on VA ECMO, but he died anyway. And that is a rapid-fire overview of calcium channel blocker toxicity.